So, without further ado, I'd like to introduce our speaker for today, who is a Dr. Leonard Hock. And he is a longtime friend and supporter of the FSGA. He will be presenting at our conference in July, and his topic there will be about prognosis and developing a plan of care. So, those of you who have seen him before know that he has excellent information to share with us. Dr. Hawk is a palliative consultant from Orlando. He has a special focus and interest in geriatrics and end of life care. He has board certifications in internal medicine, hospice, and palliative care. He's a certified medical director of long term care facilities, and his interest is in hospice, palliative care, and his work has resulted in the development of a palliative case management model for acute care hospitals. He's a national presenter on medical and scientific and cultural issues. He was elected a Master Fellow in the Gillum Society of Master Fellows. That's a really big deal, folks. His energy and interest is in medical direction and the improvement in patient care through active physician leadership. And he's been a touchstone for FSGA over the years. He continues to meet with our members, to consult with them, and to provide guidance to us. So I'd like to thank him very much, and you guys are going to enjoy the webinar today. Thanks, Dr. Hack.
Well, thank you, Gina. Can you see me and hear me?
Yes, you look great.
Well, let's see here. Let's see if we can get started. And it's just a pleasure to be here with you all. Let's see if we can do this. There we go.
Looks
So
perfect, Dr. Hack.
you asked me, and other guardians have asked me about food and fluids very near the end of life. So this is something that I deal with every day. In fact, today I have a 50-year-old daughter asking me to put a feeding tube in the nose to the stomach of her 82-year-old mother who is dying of dementia, cancer, and heart disease. And the daughter tells me, I know she has those other illnesses, but we just can't let her starve. She's got to be able to eat. This is an everyday event for me. And I think probably for many of you, you have to deal with this on a pretty frequent basis. So eating is everything, or we can't just let him starve to death. So I'm Leonard Hock, H-O-C-K, not like a bird, like Ham Hock or Doc Hock. And I have those kind of credentials. You know, in healthcare, we say the doc with the most initials at the end wins. I have a little consulting company, serious illness consulting company, that is called Hock Talk, not too cute. And my telephone number, this is my personal number. And I gave it to you last year at your big meeting, and you're welcome to use it. When I'm talking to a patient or a family, I don't take my phone in the room. So if you call me, you'll probably leave a voicemail. If I'm not with patient and family, I answer promptly. I'm happy to be able to help. If you'd like to contact me for any reason, it's my name backwards, all lowercase. So it's Hock Leonard, middle initial R, at gmail.com. So Hock Leonard R at Gmail. I don't have any disclosures. I'm not being paid by anybody. I don't have any reason to give this talk except to help you do a better job with your wards, even in your personal life with your friends and family. So let's talk about, assumptions. Let's talk about assumptions here. I believe that you as guardians have dealt with the artificial hydration question pretty frequently, what to do. I know that my wife and I had a trust drawn up, first trust ever. We thought it's probably time. When you think it's probably time, it should have been sooner. So we had a trust drawn up, and it's 42 pages, and one paragraph in there says, Would you accept artificial hydration or would you not? I thought it wasn't nearly enough, but an attorney drew it up, not a physician. And so in that 42 pages, I have one paragraph that says what I would want. So I think you've probably dealt with this issue. In the face of serious decline, you've probably supported the family or the physician's wishes to have feeding tubes put in, and you've probably received conflicting information about food and fluids near the end of life. And you may actually disagree with some of what I'm going to say today. That'll be interesting, but I want you to take it into account that it's 5 decades of clinical experience working with these kind of patients. So, and if you've done other work, I'd like to know near the end, or perhaps you can put that in the Q&A to Gina. So bring your information. This is my goals and objective for you. So I want to bring you information regarding food and fluids near the end of life that you can use in your everyday practice, taking the best care you can of your wards. We'll discuss the benefits and burdens of food and fluid. Who would even think that burdens would be part of what we would be talking about when it comes to food and fluids? It seems like they would just be a benefit. We have to have them, don't we? Or do we? Well, food is everything, eating is everything. So in the prime of our life, from the time we're born and our mother raises us to her breast, food is love. So a baby at a mother breast or bottle, Thanksgiving time for families, having that favorite meal, an old family recipe, food is love. Cultural food, Thanksgiving food, family favorite food, comfort food, food is love. And of course, it's health. So we eat food, we eat a balanced diet. You know, when I was in high school, I said if you had to pick one food that you could eat only that for the rest of your life, what would it be? I picked a cheeseburger, and I picked it because it at that time had the 4 major food groups. It had dairy, meat, vegetables, grain. So cheeseburger made it all. So today we have different views of what a healthy diet is, but we eat to be healthy, to sustain ourselves, to be vigorous, to be strong. Food is love and health. So food through life, well, we develop our favorite foods. As children, we, I think, are obliged not to like broccoli, asparagus, and spinach, but Popeye loves spinach, so I guess we could grow into it. So we have our favorite foods. We have the foods we don't like just based on our palate, and that's perfect. We should do that. We have health diets. We have low cholesterol diets, weight reduction diets, all kinds of healthy diets. And then we have specialty diets for food sensitivities. People who have allergies to shellfish or peanuts, people who have sensitivities like to gluten, or people who have intolerance like to lactose. So we all know about those kind of diets. So those are the diets that the food is everything during the prime of our life, when love, health, and special diets make a great difference. Well, the difficulties can occur as we move beyond the prime of our life to later phases of our life based on age or health conditions and difficulties with our health at any age. So the difficulties with food, very common, can be they're just difficult to chew. With bad teeth, partial plates, it just doesn't work well. So difficulty chewing. We all would know something about that, not personally perhaps, but at least we know that that can be a problem. TMJ, the temporal mandibular joint, can really get achy, arthritis, inflammation in a few patients. So that might be difficult for chewing. And then swallowing, as we move past the prime and even the advanced phases of our life, swallowing can be a real challenge. And I want you to think about this. Swallowing is one of the most complex muscular things that we do. We have to lower our soft palate, thrust the back of our tongue, push the food, moist food, to the back of our mouth, close our epiglottis, the flap that closes over our vocal cords to protect us from choking, and then all of those soft palate tongue thrusts have to move the food to the top part of our esophagus, and then peristalsis, the normal movements, takes it on down to our stomach. The lower esophageal sphincter at the bottom of our esophagus, the top of our stomach, opens to let the food into the stomach and then closes to keep it from refluxing back up. And anybody who has ever had indigestion or heartburn knows about that refluxing back up. That might come into play later in our talk today. So swallowing is quite complex and it takes strong muscles. So if a patient, a ward, a resident, is too weak to walk or to obtain their own activities of daily living independently, if they're too weak in their legs, they might be getting weak in this complex swallowing mechanism. And difficulty swallowing is dysphagia. Dys is bad, phagia is swallowing, so it's bad swallowing. So one of the big challenges for us geriatricians, palliative docs, internists, is that if someone is starting to have some difficulty swallowing, it's not just that they're having difficulty getting food to start their esophagus, peristalsis, lower esophageal sphincter function. It is if their epiglottis does not cover their vocal cords, they're going to choke. Choking is aspiration. Now, we all aspirate a little bit every day because we have mucus saliva in our mouth normally, so we can talk, so we can mix it with food, so we can swallow it. And we all protect ourselves from that aspiration by clearing our throat. That just kept me from getting pneumonia because I might have aspirated my own saliva. And that's very important as frailty becomes the norm in very ill people or very old people, but very frail people. So swallowing can become difficult near the end of life. You know, I didn't think to write down what do I think near the end of life means. Well, it certainly could mean hours and days, and probably, we'll talk about this, it could mean weeks. So maybe months. So if people have weeks or months left to live and they're having difficulty swallowing, is nutrition the most important thing for them at that time? Maybe. So we talked about food through the life. Here's function through life. I think you saw this same slide last year at the convention. It's one that I use. It's one that I show to patients and families. It's one that I share with other physicians and nurses. And this is so valuable, but except in palliative care, in my specialty, it's almost never used. So here we are, upper left, we are 100% full ambulation, full activities. We're attending webinars, we're giving webinars. Our jokes are funny. We can still think quick. We can't run the mile in 7 minutes anymore, but we can still walk a mile. Our self-care is 100%. We don't need anybody to toilet us or lift the spoon to our mouth. Our intake is normal, and we have full consciousness. Now, at 90%, maybe we have high blood pressure, take a medicine, but we can still do everything. We see the doctor once or twice a year to be sure everything's okay. At 80%, maybe we have a little sugar control issue and high blood pressure. So we're a little bit weaker, but we can still carry the laundry to the washer and dryer. So we can still work. Our self-care is independent, and we're still eating normally, maybe a little bit less because we're on a diabetic or a low salt, high blood pressure diet. When we get down to 70%, we can't quite do everything for ourselves. We can't pull the trash can to the curb. We can't carry the laundry basket down to the basement. No basement in Florida. So we can't do all those things alone. When we're down at 60% in our performance, then we're not going to work. We don't have the same activity level. Self-care, maybe we need somebody to help us dressing, maybe not toileting or bathing, but maybe somebody to help us get our shirt and slacks on when we're down at 60%. Look, our intake is normal or less. That less matters. We're still fully conscious, under our gallery over there. When we're down at 50% on the Palliative Performance Scale, please Google this up, PPS, Palliative Performance Scale, so valuable, you'll use it all the time. When we're at 50%, we can hardly do anything. Walking is a challenge. We may need to use a walker, a cane, a hurricane, you can get them on TV, or even a wheelchair. So we may need some help. Self-care, we need more help. Intake is normal or less, and less should now be capitalized. When we're at 40% is a time when families at home have challenges taking care of us because we need too much care, too much medication. We need help toileting, bathing. We have bowel and bladder accidents. We're not very mobile. We need to have lots and lots of care and attention. And it's about here where people go to long-term care, to custodial care, nursing homes. At 40%, even if you lived in a continuous care retirement community or assisted living community, when you're at 40% on the Palliative Performance Scale, the assisted living faculty may say, we think that he needs a little more help than we can give him. He's not quite in a place where he's independent or even needs a little assistance. He needs a lot of assistance. And it's at this 40% where people are so weak, they start to have that difficulty swallowing, all that complex muscle movement to get food safely over our airway, over our trachea, and down into our stomach. It's here when we start to see choking and gasping, wet breathing, gurgling, and they have difficulty swallowing. And this becomes a real problem, airway protection. 30% is even worse. People are really very sick and they're either in the hospital or they should be, or they've decided never to go to the hospital. At 20%, they're critically ill. At 10%, they're actively dying, and that can be over hours or a few days. And at 0, they've taken their last breath. It's important to remember this because let's look at how people die. So the line across the bottom is time, and the performance scale is over on the left. So we're all at 100% and we're living life pretty good. Maybe we take one blood pressure medicine or just have a checkup from time to time. But then over there, where I am on the right, something happens. An accident on I-4 or 95, a pulmonary embolus, a hemorrhagic stroke, a heart attack, homicide, suicide, an accident, falling off the roof when you were cleaning out the gutters because you didn't buy that stuff they're selling on TV. So that is the drop like a rock, living life pretty well, and then sudden death. So swallowing food and fluids at the end of life, it's not a concern for this kind of life and death. So here is the gradual decline. Now, these people who have neurodegenerative disorders, Alzheimer's, Lewy body, Parkinson's disease, ALS, neurodegenerative disorders may not start at 100% on our Palliative Performance Scale because something has already weakened them, but their decline over time, and this could be years over time, is slow and gradual and predictable. So you see, when they're still at 50%, they're probably swallowing safely, protecting their airway. But look at the slope of the curve out toward the end of their life. Toward the end of their life, when they're 40, 30, 20%, they may be having some trouble. But the slope of the curve is quick. They're losing time quickly. Families of your ward, my patients, often say, but doc, we know he's had Alzheimer's for 6 years, but just 2 weeks ago he was driving to Publix and now he's in the hospital choking with pneumonia. How could it be so fast? And how it could be so fast is that's nature's way. That gradual, predictable decline becomes a rapid and shocking decline. And I'll bet every one of you has parked next to that guy in the Publix parking lot, driving 2 weeks ago, choking with pneumonia in the hospital today. So on these patients, swallowing is a problem, aspiration, choking is a problem, nutrition is a problem, food and fluids, love and health, and the family members, the friends, the loved ones, or even the physicians are saying they're not able to eat or they're not able to swallow safely. Do we need to start food and fluids artificially at this point in their life, at this rapid decline on that palliative performance curve? Now, cancer patients, neurodegenerative patients, Parkinson's, ALS, dementia, Alzheimer's, all have this general curve. What about this? Your wards who have good weeks and bad weeks, who have bad days and good days? Well, these people often have heart failure or respiratory failure. So they're 100%, but they have had a heart attack. Their heart's weak, the heart muscle is weak, it gets congested, that is congestive heart failure. So you can see that first rapid decline down to 70%, but they come to the hospital, we give them diuretics, water pills, Lasix, Demodex, we give them oxygen, we put their legs up, we elevate their legs, we put them on a low salt diet, and we rescue them. And the family says, or the patient themselves, your ward, says, well, look, I'm a real fighter. I bounced back. Do you see how they were 100%? They dropped down to 70, but then they bounced back not to 100%, but barely 90% on the palliative performance scale. But then they go along and they have another event. So they drop down to 50%. They come to the hospital and they're rescued again, the same way, same treatments, and they bounce back. They fought back. This slide, this is the bouncers and the fighters. They fought back, their strength, our care, and they bounced back. But look, they only bounced back to 60% this time. So for you who know things about statistics, you can see that the slope of the curve, except for the naders and the zeniths, they never get as well as they were before, and they're losing strength the whole time. So out toward the end, they also have that rapid decline. This is the real challenge in communicating the clinical decline, because the patient themselves, the ward themselves, their families will say, but he's a fighter and he's bounced back 5 times before. He'll bounce back this time. All he's got to have is food and fluids. Doc, you've got to figure out, if he can't swallow, how he can get that. And this is what I'm dealing with every day, a couple times a day, because food is love and health. The family, the people who care about your ward, they want them to have the love that food brings, and they want them to have the health and recovery that they think food brings. So, sounds good so far, huh? So, starving. So, near the end of life, not for the drop like a rock patient, the heart attack that dies in place, or the automobile accident on I-4, but for the gradual predictable decline, or the fighter and the bouncer decline, are they starving to death at the end of life? And let me say to you what I cannot say to patients and families. What we know clinically, what we know in research, what we know from decades of experience is near the end of life, in those last hours, days, or weeks, a few to many, the patient is not eating because they've started the dying process. They aren't dying because they're starving. They don't eat. Their body doesn't physiologically crave food, calories, proteins, fats, vitamins, because they're not digesting. As weak as they are in their legs and their cognition, their stomach is that weak also. So if we artificially feed them by taking a spoon and cramming it in their mouth, or taking a tube in their nose, or putting a peg tube through their stomach, and we fill the stomach, we fill a stomach that is weak and exhausted, weak like their legs are exhausted, weak like their mind is exhausted. So we fill the stomach, this bag of flesh, with nutrients that can't be digested. They're not having that peristalsis, that gurgling in the stomach that embarrasses you in a quiet meeting or church. They're not having that because their stomach is just this lazy bag, and it's holding all this, but it's not being digested. So what if a little bit of it is being digested? Well, their liver, their kidney, their digesting metabolic organs are also failing. They're on that curve of decline as well. So the patient is not digesting and they're not metabolizing. So if we cram food in their mouth, well, they're likely to choke. But if we put a tube in their nose or through the skin into their stomach, then are we really benefiting them? Their decline is not based on nutrition, it's based on their underlying disease. So near the end of life, in chronic disease, predictable decline, or the fighters and the bouncers, we could be making them uncomfortable without benefit. So the benefit of food and fluids is great, it's wonderful, until we get to a certain point in our life, a point that the palliative performance scale shows, and then the burden, it's just counterintuitive, isn't it? That the burden of food is greater than the benefit of food. But it absolutely is in that final phase and that downsloping part of the palliative performance curve. So near the end of life, what does that mean? Days to weeks? Well, the appetite declines. There's physiologic decline, as I just said. Weakness prevails. Swallowing is more difficult. So I've said for 3 decades as a geriatrician, whenever a swallowing study is ordered in the hospital, it's almost always going to be positive for failure. The patient couldn't swallow safely, or we wouldn't have ordered it. We're watching the patient choke. We're watching them sputter. We're watching and hearing the mucus in their airways that shouldn't be there. So when we order the study, can they swallow safely? It would be a surprise if the result is they do just fine. In fact, I've never seen that they do just fine. So weakness prevails, and it's not only the weakness in their legs and their swallowing, it's the weakness in that lower esophageal sphincter. So when we put things down into the stomach, the speech therapists say always sit straight up, because when it goes to the stomach, we want gravity to keep it down there. But if someone should ever recline or even lay down, then their stomach and their esophagus and their trachea are all horizontal. And if that lower esophageal sphincter that lets food into the stomach but should keep it from coming back, well, it's just as weak as everything else. So the food does come right back up the esophagus. And if that person is horizontal, it spills straight into their airways, straight into their airways. So digestive changes, the stomach isn't strong to digest. Metabolic changes, the liver, the kidney, the mitochondria are not healthy to metabolize. So swallowing, digestion, metabolism is all failing near the end of life. So food and fluids, love and health, so we can shovel it in. And I hear the nurses, aides, technicians telling me, yeah, they don't want it. They turn their face to the side. They clench their teeth, but we keep shoveling it in. So the two kinds of tubes that are common is a nasal tube called a Dobhoff. It's a little thin, a little smaller than a straw. Actually, these Dobhoff tubes, I think, are just torment because now they have to be tied in the nose with what's called a bridle. We stick a instrument up in the nose, thread a bridle behind the septum in our nose. Can you imagine that? And pull it out the other side. Goes in one side, strings around, pulls out the other side of our nose, and then they tie it to this little tiny tube called a Dobhoff, Dobbhoff tube. But patients can be discharged from the hospital with a Dobhoff tube because it'll tear out their septum, they'll pull it out, it'll come out. So a Dobhoff tube is really only a hospital-based intervention to try to get food and fluids into a lazy stomach. The PEG tube, you're commonly aware of, goes right through the skin into the stomach. And PEG stands for percutaneous, through the skin, endoscopic, with an endoscope, gastrostomy tube, gastrostomach ostomy hole. So what happens is the endoscopist scopes the patient, they inflate the stomach with air, they light a very thin area between, because the endoscope has a bright light on it, they shine that light through the skin. You can see it. It looks like a little Tinkerbell effect. They prep that area so it's sterile, put a little numbing medicine, make a tiny little incision, stick a needle in, and through that needle they put a thread, a suture, and then the endoscope with a snare grabs that, and it's all pulled out so it comes up and out the mouth on a thread. But now the thread is still hanging out that gastrostomy tube, so in and out. So we then tie the PEG tube itself to the thread at the mouth and start pulling the thread suture out until it's down in the stomach. Then they re-endoscope, make sure it's in place, and the patient can be fed directly through that tube into a lazy stomach with a lazy esophageal sphincter. So we can get 2,000 calories, all the hydration and nutrition that a healthy person could use. We can give them 3,000 calories a day. So is that going to be good for them? They can't really digest it near the end of life. Now, these PEG tubes can be life-saving in esophageal disease, esophageal cancer, in a small stroke that's temporary and they're going to recover. PEG tubes can be a miracle form of nutrition delivery, but near the end of life, hours, days, and weeks, the patient can't digest, they can't metabolize. So we thought that these PEG tubes or forced feeding would help them get stronger, gain vital weight, heal bed sores, and get better. And over the decades, we proved these PEG tubes with artificial nutrition do none of that. They don't necessarily make their life longer when they have chronic disease. It doesn't make their life better. In fact, we see that the discomfort of these tubes is much greater than the benefit. Even demented patients who are confused, don't like this hanging on their side. They pull it out, they pull the Dobhoff out. Starts to be a signal when we've placed those tubes 2 or 3 times and the patient pulls them out every time. They might not be cognitive to have decisional capacity, but they know they don't like that, and they could be sending us a message. Well, how about intravenous hydration? You know, in the hospital, everybody has to have an IV. It's just part of the symbol of caring. People have to have an IV. So it may be a simple IV of just dextrose, sugar water to hydrate them. It may be normal saline and dextrose. It could be other. But for nutrition, they have to have either partial parenteral, meaning IV, parenteral nutrition, or total parenteral nutrition. To get total parenteral, that means all the nutrition you need is going to go through an IV. Well, you have to have a huge vein. So it has to go in one of the veins of the neck or the subclavian. You have to have a huge vein because total parenteral nutrition is so potent. It's acidic, it's nothing but calories and protein. And if we put it in the veins of our arms or legs, it would burn them up or sclerify them within just hours. So it has to have a large vein. Anytime we do anything IV, we have the risk of introducing a blood infection. It happens very common. Digestion doesn't have to happen because this has already been digested, chemically formulated, but metabolism has to still happen to all this to make it useful nutrition. And that is the challenge. We use TPN, total parenteral nutrition, very frequently in the hospital. Trauma units, burn units, post-surgical units, but those patients aren't actively dying at the end of their life. They need this nutrition in the face of a catastrophic illness, trauma, or surgery so that they can recover. They have an opportunity to recover. But near the end of life, total parenteral nutrition was tried for a while in the 80s when it was brand new, but it was just a mess for the patient. The cost is extraordinary, but this is not a talk about cost. The discouraging burdens were much greater than the minimal, if any, benefits of total IV nutrition near the end of life. Well, how about IV hydration? Well, she's going to dehydrate, or she's already dehydrated, the loving daughter will tell me, and she is a loving, strong advocate. So shouldn't she have IVs? Well, interesting, near the end of life, remember that bad metabolism, we want to hydrate people so it fills the vital vascular space, the blood vessels, so that the blood can circulate, so that the kidneys can clear it, so we're not dehydrated. So the vital vascular space is very important to hydrate. But what happens near the end of life is that when we give fluids, either force them with ice chips or water or thickened water or jello or IVs, is the fluid doesn't go where we want it to, where we need it to, into the vital vascular space. You've seen this with your family, you've seen this with your wards, that what happens is it goes into the tissues, so they get edema or swelling of their ankles and legs. It goes into their abdomen when they have cancer or liver failure or kidney failure, and it causes ascites, and it's uncomfortable and it's not healthy. It goes into their pleural space and they get pleural effusions, which is fluid between the lungs and the chest wall. It decreases breathing, it's uncomfortable, it's not vital, it's not healthy. So if just IV hydration, not nutrition, was helpful near the end of life, it would be helpful if it didn't cause swelling or edema, if it didn't cause ascites in the abdomen, if it didn't cause effusions in the chest, but it does. So hydration near the end of life is not a benefit, great burden. So remember, I said I can't say this to families because we deliver facts, veracity, honesty, in a very thoughtful, word-chosen way. So I said, they're not dying because they're not eating. The fact is they're not eating because they've started the dying process. Another thing we can say about hydration, and we know this in palliative medicine, hospice medicine, geriatric medicine, is, forgive me, this sounds rough, but a dry death is a good death. When we hydrate people with IVs, they'll get the swelling in their legs, the ascites in their belly, congestive heart failure, pleural effusions, and toward the end of life, in the last few days, they'll get mucus and wet breathing in their trachea, because when we hydrate them, we hydrate their mouth. Remember that saliva and mucus that's so good for speaking, being comfortable, mixing with food? Well, if we hydrate people, they make saliva, but they can't protect their airway, so it goes right down into their airway, irritating, and they get wet breathing. Long ago, and in novels, it was called, and some people still call it, the death rattle. And that's too much fluid near the end of life. So is there a benefit? Well, if someone's not near the end of life, food and fluids are love and health. But near the end of life, we have to reevaluate whether everybody has to die with a peg tube. They don't. They don't. So, nausea, bloating, diarrhea, aspiration are all the burdens of artificial nutrition and hydrations somewhere near the end of life. Near the end of life, that vital vascular space is what we want to hydrate, but we don't. I got ahead of my slides, didn't I? So we have swelling, effusion, ascites, heart failure, and even wet breathing, that death rattle. So I've got, I think, about 15 minutes to be there for you, your comments, questions, or your debate. If you think that I'm wrong about these issues, I'd love to hear that too. So I'm at your service. Gina?
Well, Doc, I just, on behalf of everybody, I'm sure the applause are resounding in our audience of 200 here. But I just want to say thank you for breaking this issue down so clearly and giving us all of this information when we're making decisions like this, when we're considering procedures like this. All of the information that we get is immensely helpful. So this is a great talk.
Well, you're very
And I'm,
kind. You're very kind
oh,
and effusive with those compliments. Gina, I think I put a couple questions out there to the audience before. Did I put a couple of poll questions?
well, we do have a couple of polls. I'm gonna raise one now. We're gonna launch this poll. Hold on,
Oh.
let me do this. Let
So
us,
does a PEG tube, a feeding tube placed through the skin of the abdomen directly into the stomach, eliminate choking and aspiration? We should have had a before and after, before the talk and after the talk.
let's see as the polls up. We have we'll let this run for a couple minutes here. Well, at least we know our audience is very engaged. Where can see many folks
So
participating in our.
this is a wonderful teaching point opportunity. So a PEG tube that goes directly into the stomach and puts the nutrition, the supplement, the Gevity or Boost or Diabetic Resource directly into the stomach. The thought was when PEG tubes were new in the 80s that nobody would choke or aspirate because the food doesn't go over their vocal cords. They don't even have to swallow, so they won't choke or aspirate because all the nutrition is placed directly in the stomach. But what we learned by the 90s and is confirmed continuously is that if they aspirated once in a while before the PEG tube went in, they would aspirate all the time, 100% after the PEG tube goes in. And for two important reasons. Yes, the food nutrition supplement is delivered directly to the stomach, but two things. One is we're hydrating that patient. And with hydration comes saliva. So their uncomfortable dry mouth becomes a comfortable moist mouth. But we make quite a lot of saliva every day. And if they can't protect their airway, it's going to go straight down into their trachea. That is aspiration. The second reason is if we fill their stomach and they don't sit straight up, if they lie back or lie down, like they always do, then what happens is that full stomach, remember that lazy bag of flesh is not gurgling and peristalsing. It's not moving that nutrition forward to the duodenum and the small intestine. And that lower esophageal sphincter is weak. So when someone lays down, that stomach full of nutrients comes right back up the esophagus and spills into the trachea. So the answer is no, it does not eliminate choking and aspiration. So if we think we're going to benefit choking and aspiration with a PEG tube, we probably shouldn't put it in.
Excellent. Okay, thank you, Doc. Let me just go through a couple of the questions here and we'll try to get to everybody's.
Oh, sure.
We have a thank you from our guardian Arnellis. Our guardian Mary, she would like to know what kind of language do you use to educate an adamant family member that a swallow study be done on their family member with stage 4 esophageal cancer, dementia, and who's also a nonverbal patient.
So that is every day in my specialty, and the language that I use is always truthful, but words have been chosen over 3 decades of saying the wrong word and never saying that again. But it's also important based on the family, their culture, their belief systems, what they want, and how they see this. So I sit and I ask questions. Do you think now nutrition is the most important thing in your loved one's life? Do you think that a negative swallow study would make a difference in the care going forward? Or what if they did choke on everything? What would we do then? So I ask them the what would they want, what would their loved one want if the test was positive or negative? You'll often find out, well, he always said he didn't want a feeding tube, but we wanted to see whether tapioca would be safer than barbecue. So they can ask those kind of questions and we try. But I deal with them by asking, asking, asking. It's the dialectical palliative conversation instead of telling. When we tell somebody anything, they have the opportunity to deny it, to not believe it. But if we ask them, they have to intellectually process it. But beyond the swallowing study, I say, well, do you think he would want a feeding tube? Do you think it would help? Because here's some things we know. So hopefully that's help. Asking is always better than telling.
Good advice. Um, we have another question from our guardian Pam. Aren't swallow tests also called for when a ward presents with pneumonia and is old and frail, or do they listen for the stomach gurgles always?
Well, it's kind of a two-part question. The physical examination of patients over the last 10 years has really changed. We don't do so much listening as we used to. I'm still one of the only doctors I know that carries a pen light so that I can, check their throat and their eyes. And uh, most docs don't even do that. So a swallow study can be warranted, and it may be a very good thing because not only is it positive or negative, but it can guide us about can softer foods, if we puree the food, if we add thicket to their Kool-Aid, can they swallow it safer? And the answer is usually yes, they can. So a swallow study, an MBS, modified barium swallow study, can be useful in saying what kind of consistency should they have. Even in that TMJ and dental issues, softer foods can work a lot. It doesn't mean aspiration will go away, but it does reduce it. And as I said before, we all aspirate in our everyday life on tea or milk or something. Just clearing our throat protects us from pneumonia.
Okay, thank you. We have a comment from our guardian Richard. This is such an important message that more people need to hear. Thank you, Dr. Hack. And
Thanks, Richard.
another question from our guardian Pam. Some patients scream for water and hospice declines the request. What are your thoughts?
Well, I've never heard of that. People do want water, and I've never heard hospice would decline anything. Hospice comes from the word hospitality, and it means to grace, to invite in, to comfort. Now, they might choke on water, but in hospice, actually, aspiration is less a clinical concern than it is in curative medicine, where we expect recovery and regaining health. But water can be delivered in lots of ways. Little crushed ice chips melt so we don't just get a big cup of water that goes straight down into the lungs, but it allows the patients to melt it and swallow and protect their airway. We can actually add thicket, which is starch, to water. It's kind of uncomfortable to chew your water, but it happens. So if a hospice is refusing, tell them to call me. They shouldn't refuse anything that a patient asks for and anything that's comforting.
Great. You have a lot of folks complimenting you, thanking you for the excellent presentation. Great job. Thank you very much. Amazing presentation. Thank you. We have a question from our guardian, Ellen. I've observed the death rattle in a client who did not receive fluids near dying. Would this be common for some based on diagnoses?
Well, based on decline toward the end of life, even dry people, that is such an important thing to say that even if we're not hydrating them, overloading them with fluid that's not healthy, that goes to all the wrong places, even in people who are dry near the end of life, they just can't clear any of our airways. You know, when oxygen gets down to our lungs, it's 100% humidity. It's just like a rainy day because it needs to be that moist for the oxygen to be absorbed out of the air. But in our airways, that moisture can't be cleared and it turns to wet breathing. Wet breathing is a softer term for families and they get it. We actually have medicine, glycopyrrolate, that we use to help dry up the airway because mucus in the airway most of the time is not uncomfortable for the patient, but it's uncomfortable for the family to hear that wet breathing. We don't call it a death rattle anymore, but you're exactly right. And even in dry places, that's the last place wet happens.
Many more comments thanking you. A guardian saying that this is always a difficult decision, but hearing that this can cause more discomfort at the end of life makes it an easier decision. Another guardian thanking you, saying that they had a bedside caregiver in a facility keep trying to feed and drink a ward who was actively dying under hospice. She wishes that more training was provided to those aides.
Food and fluids is health and love. It's hard to get families to stop feeding. It's hard to get aides to stop feeding. It's hard to get other doctors to stop feeding. And we don't want to stop feeding until they truly are at the end of life and the food and fluids becomes a bigger burden than a benefit.
Another question we have here from one of our members, Jennifer, indicates it's a struggle to try and determine if a patient is, quote, terminal, and if they will be able to recover from an illness. What do you look for when trying to decide if artificial feeding could be a helpful intervention versus an unnecessary prolongation of life?
That is a great but complex question that requires quite a complex answer. So we've got to figure out, first of all, what is the prognosis? And in palliative care and geriatric, we have lots of tools, caring criteria, the Eastern Cooperative Oncology Group scoring card. The palliative performance scale that I showed you is one of the best. And I think I told this story at your meeting last year that I actually gave this out to my palliative nurses and said, please learn this. Not enough people know about 100% to 50%, 40% usually maximum care or nursing home, 30% ill, 20% in the hospital and starting dying, 10%. So it's very valuable. So one of the nurses actually put that in front of the family and said, look, where is your loved one in that palliative performance curve? How were they a year ago? How were they 6 months ago? And the patient themselves, in their state of decline, gives the best prediction of their prognosis. Or if you ask, oh my gosh, so much has happened in the last month to your mother. What if next month looked like last month? Remember, I'm asking again, not telling. The families often go, oh my God, if the same things happen next month as happened last month, she won't be here in 2 weeks. And you know what? They're usually right. So we ask them, based on the patient, the ward's decline in the past will predict their decline in the future. But we have many tools. If we think their prognosis is one of recovery, then they should have food and fluids. This conversation is about things we do when patients are clearly in the last hours, days, or weeks. And you know, one of the studies done about ethics in GI medicine was, does the gastroenterologist place PEG tubes in patients who only live 4 more days? Now, if you did it once in a while, who knows if someone's going to live 4 more days? But if it's half of the peg tubes that doc puts in, that's too many, too near the end of life. So we've even tried to measure it that way, but it's a very complex question. And thanks for letting me give a diplomatic, political no answer.
Thanks, Doc. We have a question from our guardian, Barbara. I experience difficulties when the PCP tries to push a peg tube at end of life, or the hospice doctor tells me he recommends a peg tube to make the family happy.
And that's the reason to put it in, to make the family happy. That's the love and health of the family. And that is a challenge every time. And that takes a real dedicated, skilled communicator and a knowledgeable person to say, will this peg tube help? So it's asking a question. Ask the hospice doctor or the primary care physician. We love doing things in medicine, but are those things to the patient or for the patient? And we have to ask the PC. I just said the doctors even recommend food and fluid in the last days of life. And starving is not causing their decline. Their decline is causing their inability to eat or to use food. So I asked the question, PCP, what do you expect the peg tube to accomplish? We know it won't heal wounds. We know it won't stop aspiration. We know it won't be more comfortable for the patient. So what do you hope to gain? Ask the question, what is the benefit and what is the burden? What's the weight of each one there?
And then piggybacking on that, there's also the comment that trying to educate the doctors usually doesn't go well. But what I'm hearing from you is maybe using some of these techniques that you're outlining with the questioning and letting the benefits and the risks come out of the physician's mouth. This might be a good tool for guardians.
So I'm actually a consultant at quality decision making, how to make good decisions in the face of serious illness. That's that hawk talk I had in the beginning. And a couple of your wards have actually called me and said, I've got this case. How can the family make a quality decision? So I am available to help. I have that little consulting service that's available. But you're exactly right. Educating the doctor, they won't listen. They'll close their ears. Asking the doctor, what's your goal in doing whatever it is, makes them have to answer that question. Asking questions is a huge teaching tool.
That's great. That's a great advice. I have our guardian Irene asking, at what point on the palliative scale would you consider a patient to be actively dying, and are there signs that we should be looking for?
Yeah, so 10% is the actively dying. They are actively dying. So you look at the sallow color, no matter what color their skin is, what their pigment is, look at their palms, look at them. They're not perfusing blood, so they're changing color. And if you don't know a color change, ask your family, is this their normal color? And the family will, because you're asking, remember asking. So look at their breathing pattern. As people get very close to the end of life, their uncomfortable symptoms like anxiety and nausea and pain, they drift down because their cognitive assets are drifting down. But what always changes is their breathing pattern. Now, we don't know how it will change. It could be rapid breathing or slow breathing, deep breathing, shallow breathing, or very irregular breathing, as the call I'm getting right now from one of my patients. So breathing changes. So we look for level of consciousness. So that palliative performance scale at 10% is actively dying. But if you look at 20%, those people are really seriously sick, usually in the hospital, or they should be, or hospice. But if they're really seriously sick and they're in the hospital, they have multi-system failure. It's not just their kidney or their heart or their liver. It's all of those things, and brain failure and skin failure with bed sores. That's 20%. 10% is the actively dying, and you'll see color change, breathing change, level of they won't be conscious. They'll be unconscious. At 20% is where they have that terminal delirium, where they're reaching for spiders that aren't there, where they're talking to people that have gone on before them. That's usually in the 20% on that palliative performance scale. Sorry, my
Um,
answers are too long.
No, they're great, Doc. It's never too long for us. We have lots of comments thanking you and talking about how informative the talk is. Quite a few people have asked if this talk is going to be available via recording later so they can review it, and the answer is yes. We will record it, package it up, and you just email FSTA, and we're happy to share it with you again. We have another question from our guardian, Diana. When someone has severe dementia, is bedbound, unable to swallow or talk, receiving G-tube for nutrition and medications, and has declined in the amount of alertness over 24 hours, when do you obtain a withdrawal of artificial nutrition? Do you wait until basically no alertness?
Well, and again, an excellent complex. I can tell you live in my world just on your side of decision making. So sometimes the families won't let us stop. The family food and fluid is love and health, and they're never going to let us stop. And we do some of these things for the family. And in palliative medicine, to palliate means to comfort. So I do want to comfort the patient, but my role is to comfort everybody. My comfort is even to comfort the family, but even the nurse in the nursing home or the intensive care unit who's feeling the moral distress of doing something to that patient, like putting food down the G tube. I called it a PEG, good for you experience, a G tube. The moral distress of doing something that doesn't help hurts the feelings of the nurses and the staff. When do we stop it? Well, just to stop the feeding, I want to be careful about I want to be careful about the legal aspects of this. Stopping the feeding, we can start or stop IV, start or stop feeding, increase or decrease the oxygen. That's not in my scope of thinking in the same concept as a declaration of withdrawal. That's just adjusting the therapeutics. So leaving the tube in place, using it for medicine. Medicine they may need and benefit, like morphine or Ativan or Zofran. So they may still need that tube for medicine, but not nutrition. Then I just turn the tube feeding down so that they're not bloated or nauseated, and down to nothing sometimes. That's just adjusting the therapeutics. I don't see that as a declaration of withdrawal like dialysis or a ventilator.
Um, Many more comments thanking you for the information, very informative. One of our guardians wants to keep you forever. No, you can't have him. He's got a lot of work out in the world to do, as you can see. Um, Somebody comments that their daughter, who is a speech pathologist, applauds you as she does, and thank you. More families need this information. A guardian is asking, does it become more difficult to make the decision to withdraw fluids and nutrition once the PEG tube is placed?
So that's an ethics question that's as old as anything artificial in terms of support. Hydration, nutrition, dialysis, ventilators. So ethics, does anybody else, so Gina, you can see them, I can't. Does anybody out there want to answer? And there's a clear answer to that question. Is it harder to withdraw once it's been placed? So does anybody want to raise their hand or let Gina know that you have the clear answer? Gina,
If
are
you
you
have
seeing
an
it?
answer, you can go ahead and throw it into the Q&A and I will read it. We can't hear you and see you. We're sure you're very smart. And in the meantime, I'll go through, like I said, a lot of accolades. Someone asking if this speaker will be at our conference. Yes, Dr. Hawk is doing a presentation on prognosis and planning, and he is slated for a Friday plenary session. So you'll want to sign up for the conference to make sure that you can hear what he has to say. An estate planning attorney wants to acknowledge that this is a very difficult subject, but this was an excellent presentation and very helpful information. And
So the answer to that question, so is it more difficult to withdraw a PEG tube, a G tube once it's in place? So ethics falls well into the palliative range, so I have to deal with ethics all the time. Ethics are autonomy. the daughter says to the guardian, I want my mother to have this no matter what. But the question isn't what the daughter wants, it's what has the daughter told us or documented that she would want. That's the substituted judgment thing that comes into your area. So ethics is part of our field. So never putting it in the first place, withholding and withdrawing it once it's been put in, whatever that is, an IV, dialysis, whatever, have equal ethical weight. So there is no difference in withholding a G tube or taking one out after it's been put in. Withholding and withdrawing have equal ethical weight. Now, do they look exactly the same in statute and law? Because taking something out, like a ventilator or dialysis catheter, could look like a withdrawal declaration. So, and usually we deal with those mostly in Florida in the brain dead patients in the intensive care unit. So withhold, never putting it in or taking it out, whatever it is, have the same ethical value.
Okay, well, I think we have reached the end of our questions here, and we just have lots of high praise for you, Doc. I just want to remind everybody, Dr. Haack will be at our conference. He is available to us. We're very grateful. Many of our guardians have called him about complex situation, and he's always gracious enough to take the time to share his expertise with us. And so sign up for the conference if you have not done so. And Dr. Haack, on behalf of everybody on this presentation, I would just really like to thank you for sharing information that makes our jobs easier and makes our decision making better for the people that we serve. So can't thank you enough.
Well, your
And
thanks
I'd
are
also
appreciated, and a lot of them. So thank you for letting me talk about something I love.
thank you. And thank you to Carrie, our partner in crime, who helps us with our webinars. And folks, don't forget to sign up for the conference and to join the FSGA. And have a great Friday. Thank you so much, Dr. Haack. Take care.